Good morning. Today I'll be presenting a case of a 52-year-old male, an IT professional, who came to the emergency room with complaints of breathlessness with bilateral leg swelling. Patient had no complaints of chest pain, hemoptysis, fever, sore throat, rhinorrhea, or palpitations. The breathlessness was present for 6 months, which was progressive in nature, which progressed from grade 2 to grade 4 MMRC over the last 2 weeks. Patient also had complaints of tiredness, and the leg swelling was present for the past 1 week. Patient gives a previous history of acute pulmonary embolism 1 year ago and had received anticoagulation for the same for 3 months, but patient discontinued since then. Patient has no complaints of orthopnea, PND, joint pains, rashes, skin tightening, or any symptoms of Raynaud's phenomenon. Patient has no history of COPD, asthma, tuberculosis, malignancy, any heart or kidney diseases prior. During the previous episode of pulmonary embolism, patient also had a documented history of deep vein thrombosis in the left leg.
What is the reason for the deep vein thrombosis?
So back then it was attributed to the patient's work life, where the patient was sitting sedentary too often, and hence he had a DVT in his left leg. But his subsequent follow-up, the DVT, the left leg DVT was not present. There was no recent travel history or no significant family history for the patient. On arrival, vitally, patient had a heart rate of 106 per minute, blood pressure of 110/70 millimeters mercury, and a saturation of 90% in room air. On examination, patient had a bilateral pitting pedal edema. Auscultation wise, bilateral artery was present with no added sounds. In the neck, the JVP was elevated, and on auscultation, S1, S2 was heard with a loud P2. Abdominal wise, there was no organomegaly, no tenderness, and CNS, there was no focal neurological deficits. The well score was calculated, which came up to a score of 7.5. EBG on arrival showed type 1 respiratory failure, and a D-dimer was done, which was 0.7. Cardiology department performed a screening echo, which showed an RA-RV dilatation in the heart. And an ECG showed sinus tachycardia and signs of RV, right ventricular hypertrophy.
That means what?
So there was tall R waves in V1 and deep S waves in V5 and V6. Okay. Chest X-ray was done, which showed normal lung fields with elevated hilar markings. Patient was initially initiated on heparin, 5,000 international units, TID.
What is the ideal dose of heparin in acute DVT? 5,000 is, you are giving it as 5,000. Suppose if the weight is very less, how do you calculate?
50 to 60 international unit per kg.
80 units per kg initial bolus, 18 units per hour infusion, or divide into 3 divided doses and give subcutaneous.
Okay. So later during the course of stay, HRCT was done, which showed no obvious lung pathologies. And a departmental echo was done, where a patient was identified to have elevated pulmonary artery hypertension.
Okay.
And then patient was followed up and started on medications for the same.
So how do you diagnose pulmonary embolism here? CT was normal. What else can be done?
A CTPA.
CTPA is ideal.
Yes, sir.
Investigation in this patient. Was it done?
CTPA was not done, sir.
So ideally you should have done CTPA,
yes, sir,
to know whether the pulmonary arteries are involved or not.
Yes, sir.
And only you can identify whether pulmonary hypertension is because of pulmonary embolism or not?
Yes, sir.
Okay. Lower limb Doppler?
So lower limb Doppler did not show a DVT this time.
Okay.
It was already not existent in the subsequent USGs, and even this time there was no.
Okay.
Patient was discharged. Patient was from our side. Patient was discharged with long-term oxygen, with 2 to 3 liters oxygen in nasal bronchs at home.
LTOT. What is the importance of LTOT? Why we are giving LTOT?
So because patient had a persistent type 1 respiratory failure, and
what will do? It will do to the pulmonary blood vessel. It is the action of LTOT. Why we are giving LTOT in? You are giving in ILD. You are giving in COPD, chronic pulmonary embolism, especially to prevent pulmonary hypertension. How do we prevent pulmonary hypertension?
like we prevent further removal.
No, what is it? You prevent something. You prevent endothelial damage. Whenever carbon dioxide or oxygen is low, carbon dioxide is high, it produces endothelial damage to your pulmonary blood vessels. That vessel will become thickened. Slowly the hypertension will increase. So if you can give a small amount of oxygen like this, 2 liters or 16 hours in a day, it can prevent further damage. Okay, it will only prevent the progression. It will not reverse it.
Yes, sir.
Okay. So LTOT is very useful in so many conditions, including chronic pulmonary embolism.
Yes, sir. So the pulmonary artery hypertension as such falls under 5 classes. The first class would involve the idiopathic pulmonary artery hypertension, or due to other reasons such as systemic sclerosis related pulmonary artery hypertensions, followed by HIV, patients with HIV or patients on certain medications like abusing medications like cocaine or certain stimulants. And also there are certain pH responders to calcium channel blockers which fall under the type 1 of pH. Type 2 is due to left heart diseases, which can be either with preserved or reduced ejection fraction. Type 3 is due
to preserved ejection fraction heart failure. What do you mean by preserved ejection fraction heart failure?
So patient has symptoms of
what is that? It's a diastolic failure, not a systolic failure. Even when there is diastolic failure from left pulmonary circulation, blood will not go to the left ventricle.
Yes.
Okay, so what will happen? Slowly, patient develops back pressure and pulmonary hypertension. So both systolic failure and diastolic failure can produce pulmonary hypertension. Diastolic failure we will not notice. Very late phase only we will detect it. Who all can develop diastolic failure? Which all types of patients can develop?
chronic.
Patient with anemia.
Anemia is systolic failure. Hypothyroidism, there is a diabetes. These are the 2 important conditions where you get diastolic failure. There are so many other conditions.
Yes, sir. Group 3 is pulmonary hypertension due to underlying lung pathologies, which could involve chronic long-term COPD patients with underlying ILD or bronchiectasis, and also patients with obesity-related hyperventilation syndrome or OSA, underlying OSA. Type 4 would involve pulmonary hypertension due to chronic thromboembolic events. And
this patient may be under this condition.
Yes, sir. And type 5 is a pulmonary hypertension with unclear or multifactorial mechanisms. Generally, pulmonary hypertension in COPD is a very bad prognosis, and it is believed that the chronic hypoxia and the emphysematous changes in the vessels would further worsen the patient. Treatment-wise, patients can be started on calcium channel blockers like nifedipine or diltiazem. Then there is PD phosphodiesterase 5 inhibitor, which is your sildenafil, and PDE6, which is your tadalafil. Then there's cyclic GMP enhancers in your riociguat, and prostacyclin analogs in iloprost and epoprostenol. Then there's a prostacyclin IP receptor analog, selexipag, and endothelin receptor antagonist, which is bosentan and ambisentan.
So all these drugs are primarily used in type 1,
Type
not in other types. Other types treatment is entirely different. That may not respond to your bosentan or other drugs.
Sir, and ideally, a right heart catheterization might be warranted to measure the pressures, the mean pulmonary artery pressures or the pulmonary artery wedge pressures, and based on that, the mean pulmonary artery pressure of more than 20 millimeters mercury. Well, the normal would be around 14. Anything more than 20 would signify an increased.
If this patient come to emergency room with acute breathlessness, with aggravation of a problem, how do you manage? Any pulmonary hypertension coming to ER with acute breathlessness, how do you manage?
Symptomatic oxygen.
You everyone. You have to tell little more. How do you manage? How do you manage acute breathlessness here? Put the patient on propped up position. Start oxygen with BiPAP. Third one, Lasix. Will Lasix help in pulmonary hypertension?
Type 2.
Any condition where there is pulmonary hypertension with little bit overload of fluid, little bit, that is enough to create issues. So Lasix may help in many of the pulmonary hypertension where the right ventricle is involved. So you can at least remove some amount of fluid from the RV, RI. So that patient will transiently improve. It is not going to improve the patient permanently. So transient improvement can happen if the kidneys are normal. So you have to give Lasix in some of the patients. Sometimes it may not work. How did you treat the patient?
So patient, over the course was symptomatically getting better, but the baseline type 1 was presence of a MASAID. We suggested long-term oxygen therapy, and from cardiology they put the patient in review, and I started the patient on endoblock T, ambisentan and tadalafil.
Okay.
For now.
Will it going to work really?
If there is an embolism, then
Ideal treatment is endarterectomy can be done, but here heparin may be work, like it may work,
yes, sir.
but you are not done a CTP, so we don't know whether it is due to acute problem or a chronic problem aggravated by the fluid overload.
Yes.
So we have to see that.
Yes, sir.
Discharge. This patient is discharged.
And discharge, sir.
Okay. What is the use of 6 minutes walk test in this type of patients?
So that'll
We will
be
be sitting in your OPD. This patient will come back for follow-up. Tell something about 6 minutes walk test.
so, there'll be acute desaturation on there'll be significant desaturation in the 6 minute walk.
The easiest test can be done by a lung specialist without involving any of the machines. You can ask the patient to walk for 6 minutes. If he is able to walk and if there is no desaturation, he is good.
Yes, sir.
It's like TMT done by a cardiologist or physician. So 6 minutes walk test is a very useful test. You can see the prognosis, whether the patient is improving or static or reduction is daily routine activities. That should be done for this patient when the patient come back.
Okay, sir.
Okay.
Yes, sir.